So I'd like to thank everyone for the opportunity to speak today. It's a great opportunity, and I welcome the opportunity to introduce QuantuMDx, one of our very own Newcastle-based companies. We're based down at the Centre for Life, and we work with DNA. We diagnose conditions from DNA. So I'm one of the senior managers or team leads. I'm a physicist by trade, so not a clinician, and I've worked in, for the past kind of 10-15 years, I've been interfacing the biomedical side with the engineering. So I look to try and interface biology and electronics or physics. So I'll go through as the presentation a few points. I'll introduce what our story is, what we think the problem is, what are the economic impacts, and the solutions. And wrapped up in there is our technology, what we do, how we do it, and why we think doing it quickly and on a portable device is important. So our story, well, it all started, the first thing I guess is our handheld device. I've mentioned it is a laboratory which will deliver complex diagnostics in minutes. So this is different from when you get a sample taken and, for example, pathology can take days. We will have a portable device, not dissimilar to the size of an iPhone, that will come to your bedside, it will come to your village, it will come into the hospital, it will come into the doctor's surgery and take the sample. And within about 10-15 minutes we'll have a result which can help inform the clinician or the doctor or the nurse a little bit more about whether you may have malaria or TB or a sexually transmitted infection. That is all possible with our handheld portable device. It's going to be done cheaply for a few dollars, and crucially, because it's portable, it can be done anywhere in the globe. It's not limited by resource limited settings. And there's been some excellent talks, and Prof. John Simpson was talking about DNA and how your DNA encodes information about you, but it can also encode some markers for diseases. For example, TB can be included in sputum samples that you cough up, and we can look at that and extract which type of TB you may have. So Quantum, as many good startup companies do, existed in a garage down in London in Surrey. A chief scientific officer came up with the idea in 2008. Wouldn't it be good to have a portable device that was cheap and quick that could diagnose disease? So we moved from London down to South Africa. We're based there looking at malaria, but the situation got a little bit hot, I think it's safe to say, and we were encouraged to leave. And we came back to the UK, and we're based down in London, and then an encounter with Professor Sir John Byrne, who's our Chief Medical Officer, brought us up to Newcastle, and we're based down at the Centre for Life at the moment. So you'll notice in the centre of the Centre for Life there's a little market keeper's house. That's our UK head office. It's a wonderful little place. However, we're, as I speak, actually transitioning to a new facility, a 10,000 square foot lab facility to the east of the city centre, and that's now where all the research has been focused and pulled together. We are about 60 strong. We're now global, so we're not just UK based. We've got presence in the UK and the USA. I've still contact with Cape Town. We do a lot of our manufacturing and development out in Singapore. But it's not possible being 60 people to reach our aggressive times to market. We are a business, ultimately. We're privately owned, and we need to push very quickly to get to the marketplace to deliver our device. And we can only do that through partnering. So we find the best people in the world who can do what we need for specific tasks. It is a complicated task that we're asking, and we partner, we outsource, we do whatever we need to do to get quickly into the marketplace. So the two, I guess, questions now is, we've got a problem, but what is the solution? So let's look at the problem first. The world, and this is actually quite pertinent, it was on the BBC News last night for those who may have watched it. The World Health Organization had come out with a statement which essentially says that we are now moving into a post-antibiotic era. This means that minor infections or minor injuries can kill. And it's not a fantasy. There is a bacteria that was identified which is now completely resistant to any antibiotics that we have. Even our last line of defence is no longer effective. So that's where we're at. So it's as much now about diagnosing quickly rather than trying to cure. We need to prevent spread and, where possible, future infections rather than trying to cure it because we're running out of tools. As things stand at the moment, current diagnostic techniques take days. That, for some people, it just isn't quick enough. And it takes days because samples need to be transported between laboratories. And again, that's crucial. So if you have a patient present to you, you take a sample off of them, and it takes days, well, they're going to go home. So they go back home, and then you have the results, and they come back to your hospital. Well, that works okay in the Western world. But if you go, for example, into Africa, where it might be 10 or 15 miles to the clinic, people don't come back. They come, they get a sample, they go away, and disease, for example, could be spreading because they don't ever come back to get a treatment. So it's crucial that we can take the laboratory to them and cut down not only the testing time, but make sure medicines get to where they need to be. So for us, early diagnosis matters. It's not just diagnosis, but if you want to prevent spread, you need to diagnose quickly and early. A recent example of this is swine flu, and we have quite a lot of information about it, quite a lot of data, so it's very useful. At day 91, the first confirmed swine flu patient was presented. So it took us about 90 days to understand that there was a flu there that we knew nothing, we didn't know anything really about. Between day 91 and day 112, there were, I guess, 5 cases. There are 3 confirmed and 2 that were subjects. But very, very quickly, in a couple of days, it starts to go massive, and now you can see the black spots appearing, so people are now dying. And this was within 4 days, people are now starting to die. It's now gone global, so you now see cross continents. And so that's the day 117, so this hasn't transferred well. By day 120, you can now see there are significant cases globally, and we're now reaching the case where within about 40 days from first diagnosis, we have cross-continent exposure, significant deaths. And at this point, there was only 40 labs in the US that were able to specifically identify this form of swine flu. So there just wasn't the facilities there to control it, contain it. But at this point, the genetic code of the swine flu was understood, it was uploaded, and then the world started to work on a treatment plan for it, and that was effective. The areas here which are grey are not areas where swine flu never got, it's where we don't have data. And again, that's crucial, because you can see Africa isn't well represented here, not because it didn't have swine flu, but because there was no means to diagnose it. So it went unnoticed. So not only do we need to do things early, but if we want to improve our disease resistance or maximise the effectiveness of our drug treatments, we need to target drug delivery effectively. And so I was opening my talk with saying, to be or not to be, do you have tuberculosis, and if so, which type would you have? We know the site of infection. The ways in which it typically diagnosed is you cough up a sample, and then it can get tested. You can look for it on your skin or in some blood. But typically you take a sample and you culture it in a lab, and then you can apply certain antibiotics to see if what's in your dish reacts. And then you get some indication of perhaps best treatment strategies. That's one approach. About 1.4 million deaths occurred in 2014, and it's now on par, or in 2014 was on par with HIV as a leading cause of death. It has significant co-infection, which is important. We need to limit the spread. And since the 1980s, disease resistance to TB has been increasing. And this is partly because the wrong treatments have been administered, but partly because it is a very progressive disease. It can change very quickly, and as such it becomes difficult to treat. Of 123,000 confirmed cases, we expect about almost 500,000 to be multiple drug resistant. So MDR is multiple drug resistant TB. And crucially, we'll see the cost implications, but extensively drug resistant TB forms about 10% of these cases. If we now look at the drug-resistant strains, so this is where we are now running out of treatment strategies. In about 2008, we can see this is a heat map, and the numbers represent per 100,000 of population. So areas that are red have got at least one person in 100 with a disease-resistant strain of TB. By about 2007, 2010, you can see now that we've got information about Russia that we didn't have before in the Middle East, and the instances of TB are quite extensive, or disease-resistant TB are extensive. And this picture continues until now in 2012. You can see that there is actually quite a large population have drug-resistant TB. So it's increasing. The instances of drug resistance are increasing quicker than our ability to treat. The economic impact of this. Well, the healthcare cost of managing is estimated by the World Health Organization to be approaching 1.6 billion. So a significant cost. This was in 2005. We're now further on. We've got more drug-resistant strains and more people with TB, so that healthcare burden is significantly more. And in the UK, it's estimated that a case of drug-resistant TB costs us about $250,000, about £150,000. So again, the fonts haven't transferred well, but a normal TB, a strain that will respond to drugs usually costs about $17,000. In instances where you have drug resistance, you're now looking at about $154,000. And in extremely resistant cases, you're now looking towards $500,000 per patient per treatment. So it becomes important to diagnose these conditions early, ensure that we deliver medication effectively such that we do not build up drug resistance. In South Africa, the costs are about 40 times greater to have someone with a drug-resistant TB in the facility. So we need to make sure we can get drugs there in quickly and effectively. So what is the solution? To take this system, which takes days, into a system that takes minutes. So all of these complicated steps which make the testing and diagnosis days, and skilled. Crucially, in order to do these tests in laboratory facilities, you need skilled workers who can understand what the pathology is, how to extract the DNA, how to read the component of the DNA which is the marker of that disease. And the process is just a lot of steps which take a few hours, but then transport as well. You end up with days before you get the result back. We have a device which takes all of this complexity, puts it on a disposable cassette, which is targeted at $10, and does it in minutes. So it's portable point-of-care diagnostics. And it does it in such a way that we take a sample. It can be a pinprick of blood, for example, if you're looking at malaria. It can be a sample from sputum if you're looking at TB. And the process of having the sample, breaking up the blood to extract the DNA, because we know DNA is what holds the code of the disease or of your makeup, We then extract the part that we want, purify it, amplify it, and then we test it on our nanowire system. So what is a nanowire system? It is, as it says, it's a wire that's exceptionally small. If you have one of our nanowires, you can, well, on the cross section of a piece of hair, we can fit 100,000 of our nanowires. So they're approaching the same size as the DNA, which means they become very sensitive to incoming DNA. And because it's based on a silicon technology, which you'll find in your computer, it's very cheap. It's been established for 40 or 50 years, and we make thousands of these detectors. And crucially, each detector can have thousands of different sensitive, or be sensitive to thousands of different diseases at the same time, because we can make thousands of detectors. So then becomes the ability to start to multiplex the system so we don't get false positives or false negatives. So we do multiple measurements of the same blood sample to make sure that we've got a very high probability and a very high certainty that what we claim, for example, do you have TB, is sure, because we've got statistical basis for it, because we measure it multiple times on a single device. And here's our prototypes. So this is not portable. It's a benchtop device, but it allowed us to start to automate the process of breaking up the blood and extracting the DNA. We then went bigger. So why go bigger when we're trying to make a smaller device? Well, what we started to learn was that by miniaturizing things, it became difficult to deconstruct or deconvolute which processes needed to be improved. By making everything bigger and much more modular, we could optimize the system as we went on, and ultimately build a system which was more effective, more efficient. And so we have. So this is about the size of a small shoebox. Now does all the electronic reading of the samples. It will detect whether there is a presence of your particular disease marker, and it does it in about 10 to 15 minutes. And this is now the current working prototype, which is currently on display at Medica. It's one of the big conferences for medical devices. And you'll see now at the top of the screen, there's a little area where we now introduce a cassette. So this has got the disposable cassette introduced to the top of the sample. So the handheld device is not dissimilar actually to about the size of a phone. It's about 3 times thicker than this phone. And it accepts the disposable cassette at the top, and in that cassette are all the necessary components to take the blood and break it down such that we can pull out the necessary DNA. And this is the current cassette. You'll see on there are, I guess, various components. The blood goes in, it's broken up here, it's purified, it gets amplified and detected. But ultimately you see everything is now on cassette. So once we've done the test, we throw it away. So there's no, and all the samples that enter the cassette remain in the cassette. So there's no danger that you'll ever become cross-contaminated by handling these cassettes. It all happens, goes in, and then you push the button, and ultimately you push the button and the device tells you whether there's a prevalence within that blood sample. So it can be used by non-skilled workers. For the first time you can now point-of-care diagnostics in the field without the need for trained clinicians. It becomes an informative device to suggest, yes, you have a disease, you may need to go for more treatment, or it may say, yes, you've got malaria and this is one of the 21, 22 subtypes that you've got. So it identifies the exact treatment that you need. For example, malaria is a very good example. At the moment, if you're diagnosed with malaria, you get one pill which treats all. Now you've only got one type of malaria, for example, so now you become disease resistant to the other 20 types. So if you ever present again with a malarial condition, there is no treatment. But with a device like this, we break it down and say, well, this is the type of malaria you've got, this is the treatment that you need. It treats the system, so then if you present again, we run you through this again and say, okay, you've got a different type, use this drug this time, and it's effective. So it breaks down this disease resistance model that we've got by just shotgun treatments. So our system, where are we with it? So we've been developing it for let's say about 5 years. We are now at the what we call technology readiness level at 6. So we're at the beta prototype stage. So at the moment in the labs, we've got people switching these devices on, running biological assays or tests through them to make sure they have clinical utility. These devices will be out for controlled trials first quarter of next year, and there'll be some. So the business side of it is there'll be some early revenue from there. They'll not be on open public use. There'll be controlled labs because obviously we need to get FDA approvals and clinical approvals, but they will be in the field as of next year. We have an interesting approach as well. Not only do we want to diagnose disease, but we want to get to a point where we can start to limit spread. We can understand where new pandemics may occur. So on our portable device, we've got, for example, GPS and communication with 3G. So in the same way that mobile phones are now globally used, even in Africa, for example, about 7 out of 10 people have mobile phones. So if we can have our device use these existing networks to transfer little bits of information, not whole genomic codes, but just a yes or no, there seems to be a new disease here, I'm standing in Gabon, beams it to a cloud so that it knows that there's a prevalence of a particular outbreak there. We can start to use these networks to understand more global patterns, and that's what we do. So we take what is the internet, and everyone's very, very familiar with it. Computers have been using it for years, everything's connected together. We then miniaturise it onto a portable device like a phone. So we now bank from a phone, we now read books, we book plane tickets, we can do all of this stuff. So it's an internet of things, but then we can take that and make it what we believe to be almost an internet of life. So we can take various measurements across the globe, pass them up to a cloud which now looks at global populace, global spread of disease, global spread of conditions. And with our device in field, because it is cheap, because we're looking at a low cost of the handheld device and a disposable cartridge approaching $10, we can have these devices with global presence. Not only that, but when they're used, if a test comes up, for example here in the red, which indicates that there is an outbreak, well, it allows governments or organisations to mobilise resource to get there. So it's not about necessarily treating on site. What it's about is enabling people to get the necessary resources there for containment. And at that point, we start to affect, quite effectively, the ability to treat and limit spread. And all goes well, everything gets treated and everyone's happy. So for us, early diagnosis matters, and next year is the big year for QuantuMDx. We have our prototypes in the labs with our first clinical trials. And so I hope that's given everyone a bit of an oversight of where we're at. So if you are down and passing by the Centre for Life, at least for the next month or so, you can do pop in. We're still there for about a month, but we'll be going after that over to the east of Newcastle. Thank you.
Very much indeed. Have we got any questions for this? I've got a quick question. In terms of, you mentioned TB and you mentioned malaria, obviously huge issues. What about other conditions?
So that's a good question. Can we treat other conditions? The answer is, or can we diagnose other conditions? The answer is definitely yes. So our device, so I'd say it's a little silicon sensor that we use. It just comes out the foundry and it's completely agnostic. It's what you then do to the surface. So how you chemically change the surface, which makes it sensitive to malaria, TB, sexually transmitted infections, some cancer markers. Indeed, warfarin assay is one of our areas of interest. As has been mentioned, actually, so the same dose of warfarin to one person isn't enough, and yet to the other person it causes them to bleed out. It's actually genetic encoded what your dose equivalent should be for warfarin. It's there. So if we understand what that is, then we can tailor drug delivery to you. So It's there. And because our model is based on DNA, essentially the way in which it works is that we take a helix of DNA, split it up. But because DNA likes to recombine, we put one bit of DNA, so the DNA we're looking at, for example, your TB or your malaria, and when we pass the biological matrix, which is essentially your blood sample across the surface, if that DNA or malaria exists, it binds to its partner because this is single, and the one that comes in is single, so they hybridise again. And that event of them recombining triggers our sensor to go, oh, here we go, we found this malaria, or TB, or sexually transmitted infection. So the sensor just measures that coming together of DNA. It doesn't matter what DNA would be. As long as there's a panel for it, what we call a clinical panel, then our device will work for it.
What about things like just get the microphone? Sorry, just the microphone.
What about things? What about things like pneumonia, which we've talked about this morning?
Again, as long as there is a definite clinical panel for it, something which can indicate that where it exists, for example, in the DNA or the bacteria, for example, if we can have a recognised known panel for it, then you will detect it.
Any other questions? Another question here. Oh.
A really sort of stupid question, but what happens to all the disposable cartridges? How are they actually disposed of? Is there not a danger that these sort of nasty little things are going to be getting into water systems in the future?
A good question. There are no silly or daft questions. What we have to do in order to meet FDA approval and sort of clinical trials is look at how these things are disposed of. One obvious way is incineration. High temperature incineration tends to deal with a lot of nasties. Where that's not the case, then they would be in the waste container of the cassette, something which would neutralise the disease. So it would be inbuilt to the point where the cassette would be administered.
Could this be used by the police force?
Yeah, again, there are particular traits. You can use them for roadside testing. For example, if people have taken drugs, sometimes that's still in the blood system and we can detect that. It's also used as quite a quantitative way, for example, for measuring alcohol, because if you put a marker, a protein on the surface of our device, the interaction with alcohol causes a change to the surface. It tends to proteinate, and then we can detect that. So again, it's used for quantitative alcohol analysis in bloods.
Could you just tell me, if you had the situation where a layperson effectively is using the machine and it's telling that person what sort of treatment is required, can you see that this could be used without any need for a clinician at all?
I would probably say no. I mean, there's two aspects of that. One is, I think, what the device should do is help the clinician come to a better judgment quickly. I think taking a clinician out of an equation introduces room for error, and I don't know that people would necessarily want to be self-diagnosing, going to the clinician with the output of a device saying I need a particular drug. I think there will be instances, for example, where it could be very, very useful if you have. Yeah, I mean, I guess lay people can use it. It will be foolproof, future-proof, and yes, by all accounts, if there is a need for it and there is a particular assay that would be useful, then yes, I wouldn't like to see it moving so far, taking clinical practice into the home by a layperson. I think it would always be.
Perhaps in the outer reaches of Africa, maybe, where there aren't very many clinicians.
Absolutely.
It might be an awful lot better than nothing.
Yeah, absolutely. I think what our approach would be for that one is, because we have the GPS and we can transmit information, we have absolute coordinates. So if we go into a village and into a hut in a village, we know the GPS coordinate. So if we then test there, that information gets beamed back to, say, a central laboratory in London. It looks at the code that comes back, says, yes, you have malaria type 5. Then we take the particular treatment for that and we can post it to that GPS location. So it still means that the clinician gets to look at the data, but that the drug gets to exactly where it needs to be.
Okay, any further questions? One more, Brandon.
So picking up that idea, the parallels already occurring with certain sort of eye disease. The Moorfield Hospital is operating sort of untrained people that go into parts of Africa and using a mobile phone take a picture of people's eyes, which is then beamed up to the cloud, and somebody in Moorfield says, okay, we've identified this, and this case, we'll therefore take our mobile hospital to do cataracts. So there's a halfway house between what you were quite rightly saying, which is taking the medical profession out of it altogether, but also making it more accessible to people, I think.
Absolutely. Yeah.
Okay, we have a final question.
Excuse me, apologies to the wife, I said I keep your mouth shut. It sounds like it's a very lucrative business that you're talking about. It also sounds like a lot of your income will be based on research work done by a lot of people around here. From the profits, the other point is, yes, there will be benefits to the national health system on epidemic control or whatever you want to call it, but we know that the NHS doesn't necessarily direct their funds to research. Is there any prospect, any policy that part of the profits of this private company will be reinvested directly into the sort of medical research that most of the patients are here and it's hoping rather will find an answer to their individual problems?
It's a good question. Now obviously as a business we've got shareholders as well who want to see some of that money. I would say that we are obviously committed to invest in areas which can develop new panels for us, new questions, new biological assays. Yes, we will look to invest that. That's a business decision. It's not one that I would necessarily make. But we're also looking at not just governments, so not just the NHS, but for example things like the World Health Organization who want to eradicate malaria in Africa. So one of their commitments is if we could get the device in on a proposed $10 cartridge, disposable, they will look to put our device in field to eradicate malaria.
Somebody's got to program the device first with the correct information. That's my point.
Yeah, the device gets programmed. So again, malaria is an interesting one. So we know almost all the subtypes of malaria. I would say we probably do know them. So what we have, because our cartridges can be, or the chip on our cartridge has got tens of thousands of sensors, potentially tens of thousands of sensors, we put each particular malarial subtype on that cartridge. So therefore it becomes pre-programmed at the point before we even shipped it. So once it gets shipped, it's now sensitive to all the available or all known types of malaria. It passes over the surface of the sample and it tells you, do you have malaria? Yes, no. Which subtype do you have? This one. So it all comes pre-programmed. There is no, each cassette that goes into the device has got a barcode on it, which tells the cassette which type of assay is it running. Is it malarial? Is it TB? Is it sexually transmitted infection? Is it cancer? So it knows exactly what each cassette is looking to do and it makes the correct judgment.
So some really good points, Ray. Thanks very much, Chris, again. So I think that final question really personified what today's event was really all about, because we sort of end where we finished, talking about the partnership, because this region, I hope we've demonstrated, has got the partnership between the basic science, the research, the clinicians, the infrastructure that's around research, the Academic Health Science Network, and the DEC, of course, the pathology node, so critical in sort of magnifying each particular part of that as we try to understand diagnostics. And there are some big questions about how companies commercialise that research, but there's no doubt that we also need those partnerships in order to get these diagnostic tests to market and ultimately to make a difference to people's lives quickly and effectively. So some very, very complicated ethical questions around research and translation that of course is an ongoing dialogue and debate which we're going to sort of try and foster over the next couple of months. Over the next couple of months, Voice North will be looking to sort of build a digital platform, and through that mechanism, we're going to be able to reach more and more people to feed into this debate. So it shouldn't matter whether you live in Benwell or Beijing. We should be able to harness that capital that's here in the room today to sort of, really feed into that process. So any questions that you have, if you go home and you're reflecting on what some of the major issues that you would like to see debated next, put them on the email, pick up the phone and let us know, and we'll be sort of spinning out the programme on ethics, on some of the really important questions around the genomes and so on, that we can really start to debate, because it does raise huge societal questions and challenges, but it's that balance between understanding the challenge and also the opportunity that this fantastic research around genetics and diagnostics particularly brings. So it's a really exciting time. Thank you very much to our speakers today, to Andy, to Paul, to John, to Chris, for contributing and giving us such rich talks about some of the most exciting developments. Thank you to the team again for organising the event, and to you all for coming. It's a real partnership approach, as I said, between the different organisations involved, but very much the start, and we'll be in touch over the next couple of weeks to give you more information on future Research and Innovation Matters events. The next one is actually a school event. We've mentioned about the importance of getting the new generation into science and inspiring the next generation of people to take this work forward. So at the Centre for Life, at the beginning of December, Sir John Byrne, who's down at the working with Paul Brennan and colleagues, is going to give a talk to 400 school children about genetics. We're also filming that, and so even though many of you can't actually attend, you will be able to see and hear that talk again over the next couple of weeks. And so a really thriving programme of patient and public involvement, and we can't do it without you. We need your inserts into the debate about science, about genetics, and really would encourage you as many as possible to continue to get involved in the deck. And if you see Helen and Helen, that's the best way, so that we can start to coordinate the public and patient involvement and make sure that whatever you're interested in, we can really direct you to the most appropriate bit of what the amazing range of activities that's going on, so that you can get a little bit further involved. So thank you so much for coming today. It's been a fabulous event. I've thoroughly enjoyed listening to the speakers. Safe travels, and see you at the next Matters event in a couple of weeks' time.